start our session, may I invite for chairing this session Dr. Debasish Bhattacharya ji, and also let me invite Dr. Co-chairman and Dr. Khadiwal Ranjan as a co-chairman. For moderating this session, may I invite Dr. Khadiwal ji.
Okay, I think Srinivas, we can straight away go to, these are interesting video clips, so straight away we can go into session and start sharing the videos. Srinivas, we cannot hear you.
Dr. Srinivas, you're not audible.
Is it audible now?
Yes, sir, a bit.
Now, is it now? Is it better now, Ekta?
Sir, I can hear you,
Yes,
but
sir.
your voice
Share
comes
your
up.
screen.
Srinivas, we can't hear you.
सर आपकी वॉइस नहीं आ रही है सर.
Is it better now?
We
आ
can
रही
hear
है
you,
बीच में.
not clear. We may start with the session.
Are you using two device?
No, only one device.
Okay.
Is it better now?
Yes, sir.
Somewhat.
Okay.
Not better. It's not better.
Okay, I'll take it till that time. Let's start the thing. So I warm welcome to everyone. So it's my pleasure to have our chairman, Dr. Debasish Bhattacharya sir, co-chairman Dr. Ekta Johari madam, and convener Dr. Ranjit Dhaliwal. So I request the first speaker of today, Dr. M.S. Ravindra sir, are you there? Dr. M.S.R. sir, are you there? Okay, can we go to Dr. Deepak Megur or Dr. Amulya Sahu sir? Dr. Deepak Megur?
Dr. Deepak is also not here as yet. You can go straight over to Dr. Sahu's.
Dr. Sahu sir, are you there? Dr. Dharmendra, Subhuti sir, we can start with you.
Arvind, are you there?
Okay, go ahead sir. Arvind Moria sir, go ahead.
Okay, I will start sharing my screen. Is it visible?
Yes, yes.
So I have two videos on the modified technique of nucleus delivery in SICS using the basal salt solution. So you can see a fully dilated pupil, and I gave a 6 millimeter incision around 1.75 to 2 millimeter away from the limbus. Then the sclerocorneal tunnel was formed with the side pocket. As you can see, the nucleus is quite big. A side port is given, and after trypan blue, a axis is made. It should be around 5.5 to 6.5 for easy delivery of nucleus. Now with the help of the basal salt solution cannula, bevel down, the nucleus is into the AC. It's not coming out. So using the BSS, positive pressure is created into the anterior chamber. Now it comes out quite easily. and then the cortical wash with the help of Simcoe cannula to have a better cannula, then the implantation of the PMMA lens. The surgery is over. Now this is the second video. Again, a 6 mm incision was given, 2 mm away from the limbus. Again, you can see the nucleus is quite big. Cornea is also hazy, and the AC was also shallow. So blunt dissection was done. Side port entry was made. Now you can see how much corneal haze is there. Again, our axis of 5.5 to 6.5 mm. With the help of the microcapsular axis forceps, entry, then prolapse of the nucleus into the anterior chamber. So it should be parallel to the iris plane because the AC is shallow. Creation of positive pressure into the anterior chamber. Now, using the BSS bevel down tip, the nucleus, it comes out quite easily from the anterior chamber. Then the cortical washout and the implantation of the PMMA lens. And the surgery is over. So it's a new technique. So how this basal salt solution works? The potassium and the sodium, they regulate the tonicity and the permeability, whereas the calcium and magnesium maintain the integrity of cell membrane and the internal structure. And the phosphate or the bicarbonate control the hydrogen ion concentration through their buffering effect. And BSS also includes glucose, which provides a readily available energy source for cells. It's not. So the advantages of BSS plus, this has an ionic composition similar to that of the aqueous fluid along with additional constituents such as oxidized glutathione. This leads to less endothelial cell loss in the post-operatively period of 5 to 10% only, as observed in 28 prospective cases. And the other methods of nucleus delivery, it was 8% to 18% in the other cases, and the post-op CCT changes were between 20 to 35 microns only. Hence, the eyes receiving BSS reported significantly lesser corneal thickness and inflammation on the first post-operative day with clear and crisp vision. So, in conclusion, the protection of endothelial cellular layer utmost priority of every cataract surgeon. And many studies prove slight superiority of BSS versus ringer lactate. And some studies have shown that endothelial cell loss is directly correlated to total surgical time and irrigating solution volume. But surgery with a ringer lactate is 30 times cheaper as compared to the BSS plus. So now you can judge who is the SICS surgeon and who is the phaco surgeon. Thank you. Thank you so very much.
Arvind sir, you said you have 2 videos. You want to go ahead with the next video?
Yeah, I have shown both the videos.
Okay. Srinivas, we have 11 participants and 4 minutes per video.
Correct.
So I think we will be taking up the discussions at the end of the session, and let us have the videos first. And can you organize somebody to call the participants? I think many of them are not here.
No. They are there, sir. I think Dr. Deepak Megur, sir, is also there. The only thing is, Ekta, are you here?
Yes,
the session was told as from 1 to 2:25, right?
No, sir. Actually, according to the updated
55-minute session,
it is 1 to 1:55 p.m.
Okay. Because in the book it was printed as 2:25. Okay, we'll go with the next speaker. We have Dr. Deepak Megur, sir, please. Please unmute yourself, sir.
Thank you so much for the invite. I'll just be sharing my screen here. Okay. So I'll be speaking on, the CCC conundrum in SICS. This is As we all know, is the slides visible?
Yes, sir, very much visible.
Okay, fine. The discussion point here is that there's no doubt that Rexis has been the greatest innovation in the cataract surgery for the last 20, 30 years. So there's no doubt about it. But in SICS, it's a little bit of an issue because especially we understand there are two main obstacles for nucleus management in small incision cataract surgery. One is obviously the Rexis size and second is the width of the scleral tunnel. So I'll be speaking on the Rexis, importance of the Rexis and how zonular stress is exerted during nuclear manipulation out of the capsular bag. So that's the issue which you are worried about. And so for beginners, what are the options we have? Of course, scan opener is the classical technique for these things, but we cannot recommend this now in this era where Rexis is the norm simply because of its safety concerns. So we always believe that CCC still is the way to go, even in SICS. The only secret here, you need to do it bigger, especially when you are in your early part of your career. So it's always going to be easy to prolapse the nucleus of the bag, and we're going to have less of an issues as far as the complications regarding the zonular. But there are certain issues with bigger Rexis. Now, this is an eye with a PMMA lens and a very large Rexis, or maybe some other form. We are not able to see the Rexis size. So what are the consequences of this is, after 2-3 years, the bag starts to contract, we have fibrosis, and you can see there is a slight decentration of the lens. What it eventually leads down is to the refractive instability. This is another case. After 2 years, we have got a very large Rexis. You can see the margin is somewhere here. The lens is displaced out. This is a soft lens. And we can see, of course, the PCO is there, a lot of fibrosis. Ultimately, what it eventually leads is we want to have a situation like this where 360 degrees of the optic is captured or covered by the Rexis margin. Otherwise, we're going to have, this is the goal to achieve, simply because it ensures long-term centration and refractive stability. Of course, PCO control is multifactorial and it's debatable, but at least for a refractive stability, we want to ensure that the Rexis is always round and covering the lens margin always. Of course, we have the advantage of using the safety net of the Rexis when the PC tear happens, as in this case, where we can achieve a perfect optic capture and still have excellent outcomes. So what are the, how do we go about this? Like, how do we enhance our skills so that we can manage to remove the Rexis even in manage the nucleus out even in a small Rexis? I think the trick here is to master the bimanual technique of nucleus prolapse. So what I'm trying to do here is just want to demonstrate this. Of course, after doing hydrodissection, you're using 2 Sinskey hooks just to push the nucleus down and maneuver it out. It's calling the wheeling technique, wherein you ensure that even in spite of a smaller Rexis, the nucleus can still be managed out. A Rexis is about 5 to 6 millimeter, and you can see the nucleus is quite bulky. The nucleus is tipped down, pushed down, and then one hooks the equator of the nucleus, and the second instrument just wheels the nucleus out of the bag. So if one can master this technique of bimanual prolapsing out of the nucleus, you're using 2 Sinskey hooks. See, this is a Rexis which is about 5.5 millimeter, and you have a nucleus which is about 8 millimeter. In spite of that, you can still see that if you are able to wheel the nucleus out using these 2 techniques, just engage one equator of the nucleus and then wheel it out. You can see that you can remove prolapse such a large nucleus as well out of the bag in a relatively smaller Rexis. So my take-home message with my presentation here is, you can start off with a bigger Rexis in your early learning curve, but eventually our goal is to ensure that we master the skill of prolapsing the nucleus out of the bag using this 2-handed technique. By this technique, we can remove a bulky nucleus, even of a smaller Rexis and a smaller pupil as well. So in initial part, you can very well do with a bigger Rexis size, but as you get experience, I think you need to concentrate on bringing the size of the Rexis down so that eventually, we achieve the goal of better refractive stability over a period of time. So in early part of the career, you take simple cases like this, you confirm, you do hydrodissection and ensure that the nucleus is freely mobile. And these are such cases easy to begin with, wherein you ensure that it is free from it and you have a slightly bigger rexus. And using 2 Sinskey hooks, just learn this technique. I think this was my tip for the beginner. These are softer nucleuses that are very easy to prolapse out. So once you have achieved this, you can then graduate to bigger, harder nucleus. With that, I would like to conclude my presentation. I would like to thank the organizers for the opportunity. Thank you so much.
Thank you, Deepak sir. Your presentation is as lucid and videos are as clear as before. And congratulations that he won the CS Reshmi Award this time. Congratulations once again, Deepak Meghur sir.
Thank you. Thank you, sir.
So quickly we move on. A request to all the presenters that the time limit is only 4 minutes, and I request the hall coordinators to please fix the timer. Do we have Dr. MS Ravindra sir yet? Or else we'll move to Dr. Amulya Nath Sahu sir, please. Sir, you're muted.
Can you see my screen?
Not yet, sir.
Now?
Yes. Yeah, you open the PPT, sir, now.
To see.
No, down. There is a PowerPoint. Open that PowerPoint, sir.
Yes, there in the right side, sir. Right side.
Right side.
Right side. Go right. There's a PowerPoint icon.
Sir, you see the pink color there? Pink color?
Yeah.
P, yeah. That is the one.
Red color. Please press that, sir. I think he has not opened the PowerPoint. Sir, do one thing, sir. You stop sharing your video and then you click on the presentation, sir, and then we'll come back to you.
Okay.
Till then, can we have Dr. Rajiv Raut is there? Or else we'll go with Dr. Dharmendra Nath, sir, please.
Yes, sir. Am I audible to all of you?
Yes, sir. Yes, sir.
Okay.
Kindly share your presentation, sir.
Okay. I'm just sharing my presentation. Is it okay now?
Yes, sir. Go with full screen mode and we can set the timer.
I'm just going for the full screen now.
Down you have, sir. That small icon.
Okay, I'm just going slide show. Is it okay?
Yes, sir. Please go ahead.
Okay. So there we have just asked to give some tips regarding the SICS. So here are some main objective is to achieve the good vision of the day one and achieve pristine cornea and achieve minimal astigmatism or no astigmatism after the operation, and the early rehabilitation and low or post-operative bills. So we have to focus on the corneoscleral tunnel, capsulotomy, nucleus management. So incision should be fornix based, and it can be straight like Blumenthal or Chevron technique and the Frown incision. So all of you know capsulotomy depends on the size of the nucleus. Right, I prefer the hard big nuclei, only can opening is good. Medium and the soft nuclei, the better it is if you have the big CCC, and the very soft nuclei, once you do the hydrodissection, hydrodelineation, naturally it is quite comparable to the phaco. You can do 5.5 millimeter CCC and you can do SICS. So just hydropresis is not much of the tips. So here is a big nucleus, cataracta nigra. Just 1.5 millimeter away from the limbus, there is a straight incision and the side pocketing is made and the side cut is given like Blumenthal. So straight incision converted into Blumenthal incision, and slowly with the side cuts, with the crescent knife, we are going up to the limit. And this is the side incision is given, going to the anterior chamber, straight way, and fill the nucleus and do the can opening technique, enlarge the incision as the desired. So this is the cannula. So dissect it from the equator side, fill it with the visco, and just take this cannula behind this nucleus, engage it and pull it out by depressing the posterior lip of the tunnel, and sufficiently it comes out very safely. And this is how it comes out, and IOL is implanted. This is the cannula. This is two curves. One is 1.5 millimeter away from the tip, and second curve is 3.5 millimeter from the tip. So this is mounted on the PFS syringe, and all the time you have the copious amount of the viscoelastic is used during your procedure. And this is how the engagement of the nucleus takes place. Just see, this becomes oval when it comes out because of the incision, and this is how the engagement of the nucleus is showing here. And it is not completely round nucleus, it becomes oval when it comes out from the tunnel. And here we are giving the frown incision, side pockets they are made, and sufficiently we go into the cornea. Side incision is given just to do the irrigation aspiration. Anterior chamber is introduced. Can opening is done, of course. And the side pockets and the side incision given. Go to the equator with the cannula, lift it up, and just see now, this is the different technique. Keep on seeing the tip of the cannula, engage the nucleus in the curve, and pull it out by depressing the posterior lip, slowly, gently. So this endothelium is very friendly to the cortical matter. This is which is epinucleus, and this is how it is comes up. Just by irrigating, take out all the lens, the cortical matter, wash it out, and implant the lens of your choice. This is how the soft shell is done. If the cell count is low, then soft shell technique or very hard lenses, soft shell technique can be achieved. And now this is different mode. If the nucleus is very small, you can cut it and shave it into 2 pieces. You have taken the nucleus into the anterior chamber, and by the cannula and the Sinskey hook, you are dividing the 2 halves, enlarge the incision up to 2 or 3 millimeter, and take it out.
Sir, please conclude.
Okay. So take home message is proper examination of the hardness of the nucleus is very important for this procedure, and see the size of the nucleus. If the size of the nucleus is big, definitely you have to make a big incision, and hardness of the nucleus depends on what kind of the procedure you want to take. And of course, the cornea is very important part, just to save it with the help of the delivery, with the help of the viscoelastic, you can save the cornea and the technique. Thank you very much.
Fantastic, Dharmendranath sir. Very, very beautiful videos. Thank you so much.
Okay.
It's always been a pleasure to meet you, to talk to you, and see your videos and your educative knowledge.
Thank you so much. Thank you so much. Very much.
So let's move on to our next speaker. Dr. Boramani sir, are you ready? And after Boramani sir, I request Amulnath Sahu sir to please play his presentation. Sir, kindly unmute yourself, Boramani sir.
Can you hear me now?
Yes, sir, please.
You can see my video?
Yes,
Yes,
yes.
sir. Play it, sir. Please
Okay.
kindly play it. Yeah.
Yeah. So I'm giving some of my small tips in SICS surgery. Now, whenever I do the peritomy and the cutting of the tenon, immediately after the cut, I infiltrate fluid under the conjunctiva. This fluid can be BSS, or if you want, you can inject anesthetic. So I form a bleb under the conjunctiva. So after the tenon also is cut, again I form another bleb under the tenon. Now the advantage of forming a bleb is that whatever bleeding takes place from the sclera, the blood cannot enter the subconjunctival as well as the subtenon space. So this way, postoperatively, cosmetically, the eye looks comparatively good because there is no red eye or subcranial hemorrhage like picture. So this is a tip to prevent blood entering into the subconjunctival and subtenon space. Infiltrate with BSS or infiltrate it with anesthetic. So this is my first tip. So you can see the bleeding, but which is coming out and not entering the subconjunctival space. So your conjunctiva remains quite clean. I do all the surgeries under AC maintainer. So here I'm putting the AC maintainer and see the side port. This is, I call as a half side port. This is not a complete width side port. Initially, very small entry is made. It is the MUR blade is not totally passed. The advantage I'll tell you when I do the capsulorhexis. Now, whenever the incision is taken, in your mind, I know the shape of the incision and I straightway start the dissection. Most of the surgeons generally they form the initial groove, but here I start the dissection straightway with the crescent knife. So there is dissection without groove. The advantage of this is that the overlapping of the edges is so fine that post-operatively you don't come to know about the wound, or at the most you can see that there is some only 2 mm dissection done. So the eye looks very good and you cannot make out the incision. So cosmetically it looks very good, but in the mentally you have to form the picture of your shape and start dissecting. Now I talked about the half side port. So when there is a half side port, you can do beautiful capsule exercise. You can see that there are no folds in the cornea. The needle is easily passing through, but still there is no turbulence of fluid. The AC maintainer is on. This is done without viscoelastics. So you can have a very totally closed chamber, perfect capsule exercise with that half thickness of the side port. So when the capsule exercise is done, then I do the proper side port with MR blade, totally entering the MR blade through the same incision. So this helps us in a good capsule exercise. Now this needle also I am doing under AC maintainer. So the capsule exercise needle is mounted at the back of the SICS hook because there is no irrigation. Just hold it like a pen and your irrigation is coming through the AC maintainer. Now this is my technique of multiple rotation of the nucleus. Even if you feel that the nucleus is free, you rotate it multiple times clockwise as well as anti-clockwise. The advantage of this is that you free the cortex from the capsule, and the capsular polishing also take place. Recently I've seen Dr. Neto Roselli's video, that is he calls it a nuclear spin. Now this is my technique of endo expression. Whenever the nucleus is stuck into the tunnel is small one, AC maintainer is on, you are working in a deep chamber. So with the SICS hook pass through the side port, I try to push the nucleus. So the nucleus will either stretch the sclera, come out totally, or it can get fractured into the scleral tunnel. So the friction is into the walls of the scleral tunnel and not the endothelium. This technique is called the endo expression of the nucleus. Whenever you are doing the capsular polishing with the AC maintainer on, to prevent shallowing of the AC with the forceps in the left hand, generally I narrow the tunnel. So only to 2 or 3 mm opening, the polisher is passed. So this helps in a very good capsule exercise. And when you are putting a rigid lens with the AC maintainer on, the moment you leave the forceps, the lower haptic hits the cornea. So you have to always support the upper haptic with the forceps in the left hand. So this way, the lower haptic remains in the capsular bag whenever you are doing implantation with the AC maintainer. So these were my 4 to 5 tips in the SICS surgery. Thank you very much.
Thank you, sir. Thank you, Boramani, sir. That was very quick and swift. Thank you so much. And everybody knows Dr. Boramani, sir. He's the chairman of ISMSICS Society. I next require Dr. Amulyanath Sahu, sir, the founder chairman of ISMSICS, to please go ahead with his presentation. And after the Amulyanath Sahu, sir, I request BNR Subuddhi, sir, to please be ready.
See, this, can you hear me?
Yes.
Yes, sir. We are able to hear you and see the videos as well.
Yeah, this is a, see, all of us know that SICS means is a big incision, and though we are reducing, I have doing a 2 mm SICS, and while my volume of cataract surgery is very high, and I have encountered no problem in doing a small incision. Though it is a grade, up to grade 4, I can do it with this small incision. If it is more than that, it is better to increase the size of the incision depending on the size of the nucleus. So 1.5 mm behind the limbus, I take this round incision and give a 1 mm back cut, and then I create the pocket, because this pocket gives me a lot of space there for maneuvering my nucleus out. So this back cut limits the size of the incision, and I do the rexis through the side port. Rexis is a routine affair. I take 2 side ports, so it helps me to take out 12 o'clock cortical material without any problems. If it is a soft nucleus, it is better to have a bigger rexis, so that the lens will not break inside. If it is a small, then it becomes fragmented and it becomes very difficult to take it out piece by piece from the bag to outside.
So I have this modified dialer. With that, I just nudge the upper side of the things, and you can break the nucleus in the tunnel, or I divide it in the nucleus depending on my convenience. So both way it works. This is a modified vectis. A normal vectis cannot take it out. It will rub against the endothelium. This modified vectis helps me to just drag it out without rubbing the endothelium. The nucleus, this is a polishing, and either I can maneuver the lens, foldable lens directly, or I can inject it. It depends upon my convenience. So those who are not doing, they may think why it is such a less, we can manage with a big one. But then if you don't have a astigmatism, if you are doing this 2 millimeter, you don't induce any astigmatism. I always take the incision on the strip axis anywhere. So those of you who are already doing hundreds of operations, they should start reducing their size, and you should know everything. 2 millimeter is possible. I am just showing it. It is possible. It is good. And a lot of this nowadays we are doing this clear lens extractions, and those are the cases where we can have a very good results. Toric IOL and all sort of things. Thank you. Thank you so much.
Thank you, Boramani sir, and
not Boramani sir,
Sahu sir, and you finished it well within the time. Thank you so much. It was really nice to hear from you after a long time, and I wish to keep seeing you smiling as always. I now request our Dr. BNR Subudhi sir, the King of Orissa, to please show his presentation.
Thank you, Srinivas. My topic is manual SICS in white cataracts. In our country and in our parts, the white cataracts are very common. We come across regularly these type of cataracts. So for the beginners, whatever I speak for the beginners only. So beginners must be very careful, because every time they will land in complication in this type of surgery. So I will show everything in the video only. So bridle suture is a must. I give the bridle suture to be very comfortable, so that the eyeball is under your control. As usual, you take the conjunctival section from 10 to 2 o'clock. Minimal cautery, I advise. And sometimes we don't do cautery even. So section about around 6 to 6.5 millimeter, because you are not very sure how the nucleus will behave in the particular Morgagnon cataracts. And achieving the perfect plane is very important. Triplane incision is very important to get the secured wound later. So if you have a deep plane, there is premature entry, and if it becomes superficial, there is a chance of buttonhole. So all the while, your blade must be visible through the cornea. And we prefer to do the Frown incision. And our sections, internal incision must be bigger than the external incision, so that it can accommodate any lens. Side port sometimes optional, but we prefer to do the side port, because many times we have to do many maneuvers. And we do the staining of the anterior capsule through the side port under the air bubble. The air bubble prevents the mixture of trypan blue with the viscoelastics. So wash out the trypan blue, get a uniform stain of the anterior capsule. That's very important in hypermature white cataracts. Now open the anterior chamber. We do under methyl cellulose only. Because it's a swollen lens, just puncture the lens, egress some of the fluid, so that it will be easy for you to do the rhexis. You see, milky fluid has come out, so you debulk the intraarticular pressure, otherwise you will have a radial tear. See how big the nucleus is. So many times you do not know what the size of the nucleus in the white cataracts. So we can do the rhexis with a forceps or with the needle. So needle, whichever is comfortable to you, but Rexis forces gives a little bit more control. Rexis about 6.5 millimeter Rexis is necessary because of this type of nucleus. Complete the Rexis. Rock the nucleus from side to side. One pole comes out. Just lift the nucleus, bring it to the antechamber. Take the irrigating cannula, then take out. So now your choice. If you want a foldable lens, can give. If you want a PMM lens, can give. So anything is good. See that it's well centered it's in the capsular bag. Just do some kind of dialing so that it goes in the capsular bag and wash out all the viscoelastic from in front of the lens and behind the lens, so that it will not give ST inflammation, post-op inflammation. So all these steps are very important. One must go methodically so that you don't let in complications. Close the conjunctiva with a small cautery, little bit minimal cautery, so that post-operatively you don't get a congested eye. So I think my video explained everything. Thank you very much.
Thank you, sir. Subudhi, sir. It's always a treat to hear from you and listen from you. Thank you so much. And I now request our another giant in the field of ophthalmology, Dr. M.S. Ravindra, sir. Dr. MSR, sir.
Can you hear me?
Yeah. The king from Bangalore. Go ahead, sir, please.
No, I'm not really king. I mean, I would like to show a video where it's really challenging to do a surgery, and that's only possible when you have MIC. This is a case where the patient has only one eye, and the other eye is blind because of glaucoma. He has multiple attacks of angle closure. Angle is very small. You can see 2 PIs have been done here, and there is hardly any space in the anterior chamber. Hardly any space in the anterior chamber. I've stained the capsule, though the transillumination is good with the microscope. There are synechae in that area. I'm going to separate the synechae, and every time I'll have to reform the chamber, as you can see here. That's a lignocaine being done under topical. I need to infuse lignocaine very little under the iris, but most of it is in front of the iris. And I'm trying stretch pupilloplasty. The pupil is so rigid. He has been using 3 anti-glaucoma medicines for decades together. The pupil is very rigid. It refuses to dilate. I didn't want, being a one-eye person, I didn't want it to traumatize the iris by sphincterotomies in this particular patient. Tunnel floor entry technique, where cystotome I'm taking through the limbus. It is not going through the anterior, through the tunnel. AC is filled. It's only about 2 millimeters deep. It's refusing to deepen further beyond this. And he's got very small field. And I'm also worried about high pressure inside the eye, which can damage the further remaining ganglion cells. The other eye is blind, I said. I could do a good Rexis because of the blue staining within under the iris. And I noticed that it's of adequate size. And that is a single tunnel that I'm making for this eye because I didn't want it to make any side ports. And inside portion of it is slightly enlarged. This is a trapezoid incision. This will minimize the damage to cornea when you are removing the lens. Hydrodissection, you should be very careful that you are not infusing in front of the capsular bag. It should be in the capsular bag. Otherwise, there will be transzonular injection with further rise of intraocular pressure. Even a small drop goes inside the eye. As you can see, and in this case, zonules will be very, very weak. And I am very careful that I am not damaging zonules any further beyond what it is there because of long-standing glaucoma. I should be very careful in removing it, otherwise zonular dehiscence will occur for sure. And I am prolapsing the nucleus into the anterior chamber. It's, as you can see here, it's possible to do it in this particular technique by bimanual rotation. The nucleus is very hard. He has waited for almost 10 years to get the surgery done. He never came back for surgery in spite of repeated advice. And I'm bisecting it with the help of a cystotome. And cystotome is again continuously injecting visco so that there's absolutely no damage to the endothelium. This is brought to the center. I'll go a little fast to save time. And that also comes out of this. Now, cortical aspiration is to be very balanced. There is a tendency for the iris prolapse, as you can see here. Iris is tumulus throughout, and I'll have to prevent the iris prolapse, but yet aspirate the entire cortex to prevent postoperative inflammation. And that's possible by infusion, controlled infusion and controlled aspiration by Simcoe cannula, which is attached to a silicone bulb. By visual guidance, I know exactly how much to infuse. If it's a continuous infusion, the chance for iris prolapse will be much more. I'm preventing iris prolapse, which never occurred. You can see the iris atrophic patches here, and these are patches where it was syndicate which are released in the initial part of the surgery. And I have to ensure that everything of cortex is removed, as you can see there. And next step will be to deepen the chamber and put the intraocular lens inside the capsular bag. That's a slit cartridge technique. And what it does is, it's in SICS, it's possible to handle very challenging cases like this without using the iris hooks or pupil dilatory devices. I could manage a very hard cataract. I could retain a rhexis there, and I could prevent the complications. With the low pressure, low infusion, low vacuum technique, I'm not further damaging very small amount of visual fields he has, and all are possible. We thought of doing a combined glaucoma surgery, but as the pressures were well under control with the medications, we would like to continue using medication post-operatively instead of risking glaucoma, hypotonia or hypertonia post-operatively. So we decided to do only the cataract surgery. So that's my presentation. And this, I would like to humbly request that everyone has to learn SICS for handling such cases safely. One eye patient, this was done yesterday. Today I saw the patient. Patient has got tunnel vision, but he's so happy that he has started seeing the world again. Thank you.
Thank you, MS Ravindra sir. Nice techniques and nice videos. So we will come back to more discussions once we have in the panel discussion after 1 or 2 presentations more. I request Dr. Nivian. Dr. Nivian? Yeah. Dr. Nivian, to please go ahead with your presentation, please. And I request all the panelists to please bear for another 5-10 minutes. Then we'll have.
Can you see the screen, Srinivas?
Yeah.
Respected teachers, senior ophthalmologists, I'm going to talk on the role of anterior vitrectomy when it comes to SICS, something slightly different from the other things. We all can have a PCR when we do cataract surgery, so there's no hiding the fact, but then we'll have to start managing it to get better results is what I'm going to talk about. So the basic principles of any management of PCR is the fear of PCR should go away, and then we should turn these fear into actions in managing them. Like how sir actually started off telling how we can use the basic principles that we do in phaco and bring it to SICS. So the principles are the same when we manage the rent. So one is the first thing is the early recognition at what step the rent actually happens. And once we find that out, how we prevent it by putting scholastic and keeping the chamber tight and making sure that the rent does not extend. And then doing a good cortical cleanup and making sure there is no vitreous that is remaining in the wound, and then placing the IOL. So now let us see some SICS cases where we apply these techniques. So the first thing every surgeon should know is the anterior vitrectomy. So in SICS, we have two, we can make another side port. So we can use these 2 side ports to perform the anterior vitrectomy, one using the irrigation, the second using the cutter. So first thing, we have a case of a rent in a small incision. I always prefer to use triamcinolone because for 2 options. One, it helps us to stain the vitreous very clearly. And the second thing is some amount of these crystals can go and prevents the post-op CME also. You can see here one side infusion cannula, the other side cutter. You can use 20 gauge, 23 gauge, whatever is available. And then always stay in the center. The trick here is don't go towards the iris because these cutters can eat away the iris fast. But then slowly times are changing. So they're talking about the pars plana approach. So we can use the pars plana approach also in managing a larger rents. As you can see, this small incision case had had a rupture, a large rupture. Again, I'm using the tricot and then wash it away so that you can see there's only the vitreous strands that get stained so that you know exactly how much of vitreous to cut. Otherwise, we won't know how much we're cutting. So we can introduce these trocars. Initially, there is a learning curve. We have a class where you can teach how to introduce the trocar assisted thing. The only advantage is the vitreous is coming from back. So once you go through the pars plana approach, you have to cut only less vitreous. See, it is almost over. So you don't have to spend more time coming through the anterior approach because sometimes more and more vitreous tends to come in small incision cataract surgery. So you can use the pars plana approach and then clear all the vitreous in the section. See, the vitreous in the center is cleared, the section. And once that is done, we should make sure we check the integrity of the capsule. That is when I think all the speakers have told the importance of converting to a rexis. So when we have a rexis, I think it solves most of our problems. So once you know the integrity is there, put viscoelastic between the iris and the anterior capsule. So this gives us a space to know exactly where we can keep the lens in the sulcus, even though it is such a large rent. So I prefer the 3-piece or the rigid lenses. They're more stable and easier to do. So you can see the first haptic has to make sure it goes under the iris. You can see the margins clearly. And I use the 2-step technique. So I just leave the second haptic. I don't try to push it inside because that can tear the margin. So go through the side port, catch the optic haptic junction. And here where you see the rexis margin, place it there. And after that, I think too much of maneuver should not be there because these structured cases, it can slip out. So once we know the stable iris, we can leave it. So we surgeons, we know sometimes we can end up with complications where we lose the bag also. So my simple choice on SICS would be the iris claw lenses. We do a lot of iris claw lenses since most of us are training institutes and we should have a backup. So after a good vitrectomy, you can see fill the chamber with viscoelastics. So these are the iris claw lenses. So you can go under the iris and make sure you clip it in the mid periphery of the iris. The trick here that is only prevents it from getting those oval iris. Catch the lens, take it under the iris. By that time, my second instrument is already ready where we are going to fix the claw lenses. And then in the mid periphery. So here also, when you have a complication, when you lose the entire bag, we don't have to worry. We don't have to refer it. We anterior segment surgeons itself can place an iris clip lens and have such good results with good dilatation and make sure you hydrate the wound. So the importance of anterior vitrectomy is the same for all cataract surgeries. It helps us because the question comes, why we need a good vitrectomy? It helps us to prevent these post-op CMEs. And also sometimes when the vitreous is pushing the lens, we all know the chances of endophthalmitis is very high when we leave vitreous in the wound, and also these decentered lenses where you can have a glare effect. Thank you. Once again, I'd like to thank the entire ISMSICS Society for giving this wonderful opportunity. Thank you.
Thank you so much, Dr. Nivian. Always quick, always smart. Thank you very much. So we'll come out to the discussion now because I don't see Dr. Parul Shah, Dr. Karamjeet Singh and Dr. Rajiv Raut. If they are there, then please let me know. Otherwise, we can start with the panel discussion now. Dr. Debasish, sir, your experts comment, please.
Yeah, Srinivas, it was wonderful as expected by the people who really do SICS. So Dr. Deepak Meghur gave us a very good demonstration of the bimanual prolapse of the nucleus through a 5.5 millimeter rexis. And definitely it helps a lot. And that was a wonderful demonstration. Dr. Amulya Sahu, our chairman, founder chairman of MSICS, he showed his usual 2.5 millimeter incision with a back cut, which gives sufficient leverage to bring out a hard nucleus and through internal and tunnel phaco fracture. Dr. Jagannath Boromani's tips were excellent. How to keep a neat eye by doing a 2-level careful dissection of the conjunctiva and the subtenon, limiting subconjunctival hemorrhages. And also he gave a beautiful demonstration of the classical Blumenthal technique, the restricted side port for the rexis done with a needle so that the rexis doesn't flutter, the chamber is absolutely closed, and there is no leakage from the side port by which the rexis is being done. So a lot of good things have been discussed, and Dharmendra gave his why pressing the posterior lip, which just says that any instrument can actually deliver the nucleus. It is just a guide. All you need to do is depress the posterior lip, have a nice internal incision, have a nice sclerocorneal tunnel, and have a nice external incision. Dr. Nivian gave us a big insight to the complications and how to do good vitrectomies, how to place the lens in the sulcus, how to do optic capture, and at the same time, the posterior retrofixation of Arishta, which is such a wonderful thing from the SICS wound construction perspective. So wonderful learning for all of us, and I would call upon Dr. Ranjit Dhaliwal and Dr. Usha Johri for their comments.
Thank you, Debasish sir, for summarizing it so well. Thank you so much. I now request our editor of ISMSICS journal, Dr. Ranjit Dhaliwal sir, to please give his expert comment, please.
I would like to add 2 points here. Whenever I saw in 2 or 3 videos, whenever we are operating from the superior side, the side port that is made with that lens tip, the sharp edge of the lens should be facing towards you, not away, because sometimes the patient may squeeze his eye and the eye goes up and the cut could become bigger. And the other point that I would like to emphasize here is rather than whenever we are going smaller with our incision, I would suggest we learn phacosection in the bag or in the AC and then move over to that part, because I would never suggest intra-tunnel phacofracture. That stretches the tunnel and creates astigmatism even with a very small incision. Thank you, sir.
Can we have Dr. Usha Johri here? Do we have Dr. Usha Johri? Okay, other things that we...
Sorry, thank you so much. I request Dr. Jagdish to give his comments, please.
Yeah.
It was a wonderful session as always, from the 2 to 3 mm incisions to the anterior vitrectomy. As Dr. Nivian has, it was beautiful, and definitely there were a lot of tips which were shared by Dr. Deepak Meghur sir for the early beginners, and Dr. Ravindra sir with his very wonderful technique of cystitome bifurcating the nucleus with the cystitome. I'm pretty sure it looks very easy, but very complicated, and it's definitely not for the beginners. Probably that is something which on a long run people could run, and especially with the anterior vitrectomy, I think for a regular beginner coming from the pars plana side is a little more difficult. He should be probably learning more from the anterior side itself than the pars planar vitrectomy. I do understand that the pars planar vitrectomy causes less vitreous loss and so on, but that's a beautiful presentation. It was great overall. Thank you.
Thank you. Thank you so much, Dr. Jagdish. Thank you, Debasish sir, for summarizing so well. Thank you, Ranjit sir. One quick question to Dr. M.S. Ravindra sir. Sir, what is the grade of the cataract would you look into when you're using the cystitome while breaking it in the AC? And is there any choice of viscoelastic you would like to use?
Yes, it's a good question. For softer cataracts, I always try with shaft of the 25 gauge needle, and most of the up to grade 3 you can bisect it without any effort. But remember that as we are bisecting it, the shaft of the 25 gauge cannula is continuously infusing, so that there is no touch at all between the cortex and the endothelium. If it is harder, first I always try, but even in this case I tried with that. See, like if you apply a lot of pressure, then the nucleus starts moving, and that's the time when you get it. Then I learned that cystitome is a great, wonderful tool that's already here, and with 2 or 3 scratches, any grade, even the black 5 grade of cataract nucleus of grade 6 can be easily, by 2 or 3 strokes you can cut it. It's a sharp tool. And the only thing is you'll have to support it, and you have to ensure that there is no endothelial damage, as rightly said.
Oh, yeah, it's HPMC, Srinivas. But I would remind everybody here that Dr. MS does it so well that you must remember you're constantly, it's attached to a syringe, and you're constantly putting in viscoelastic while you are phaco-fracturing. Yeah. So it is not as it looks on the video.
Only thing is we should not have endothelial damage while touching the cystitome. That we have to. That's why it have to be tried by experts only. You suggest that, sir?
Yeah, it's HPMC all the time. HPMC is the one which protects maximally.
Thank you, Srinivas. We are bang on time, and I think we've done a wonderful job sharing the collective experience of the heads of SICS in the country. And thank you very much.
Thank you very much.
And we pass on, I think, to the next session. Let's be on time.
Yes, sir. Thank you so much.
Yes.
Thank you, Debasish sir. Thank you, everyone.
Thank you, Srinivas.
Thank you, all the
Sir.
speakers.
Thank you and bye. Bye.
Thank you, everybody. Bye.
Bye.
See you in the later.
Give you at 1:55. The hall.
Thank you.
Okay.
Thank you so much. Thank you very much.
Okay.
I would like to add, we have another session at 5:30 in the evening today.
Yeah.
Yes.
But unfortunately, we have the past president's meeting, so I have to excuse myself from the responsibilities there. I'm sorry.
Nice to see Ajit Babu Majji sir here. Majji sir has
odd person here for SICS.
Majji sir has invaded into the
next session is there. Srinivas has become anti-segment surgeon.
no.
Right?
Yes. He does a lot of cataracts.
Okay. Thank you, everyone. We'll call it. Thank you.
Thank you
We
so
are
much.
waiting for the next session.
Thanks a lot.